Hey everyone, welcome back to Dietitians and Nutrition Support. Thanks for tuning in again to this electrolyte series as we continue on our escapades and start to talk about magnesium. So magnesium, I think, is kind of one of the unsung heroes of the electrolytes. Not a lot of people think about it often because hopefully it's functioning really appropriately and there's appropriate levels in the system. But if it's not there at appropriate levels, we have a lot of concerns. And that's because magnesium is just really important. So what do we need to know about it? Well, magnesium is an intracellular cation, meaning that it's mostly concentrated inside cells and carries a positive charge. We'll see that less than 1% of our total body magnesium is seen within red blood cells. So if you're taking a serum draw, we're really sampling kind of a very small percentage, or it will register as a small portion of the total body's magnesium. And this is because magnesium is typically found stored in places like bones, muscles, and soft tissues. It's also really well regulated at serum levels because we have good regulation through the GI tract, also through our bones being able to uptake and release as needed, and through the kidneys. So that's just a few ways in which we kind of can manage magnesium status. But again, if it's irregular, we kind of have some issues. And that's because magnesium is super important as a cofactor for over 3,000 enzymes in the body. And many of them are related to ATP, such as sodium potassium ATPase. If you remember in our phosphorus video, we talked a little bit about ATP and how it's a super integral portion of energy kind of transfer. It's like sort of an energy currency that you'll see that kind of moves and is created and synthesized and then broken down to be able to release this energy. And this helps with many different bodily functions. So if magnesium is an integral part of ATP being able to function in the body, you can tell that obviously magnesium is super central to a lot of things happening. We also see magnesium being a particularly important part of enzymatic regulation for things like oxidative phosphorylation. It'll also take place as a portion of metabolism for glucose and proteins, as well as fatty acid synthesis. We also know that magnesium is particularly important for getting calcium into smooth muscle tissues, smooth muscle cells, and that helps to maintain things like cardiac contractile strength. As you probably know, that calcium is going to be an integral portion of being able to contract all of those muscle cells, and we obviously need all the smooth muscles to work. So this again leads to why magnesium is so super important for the body and something that we want to make sure we're managing in our patients. So let's talk a little bit more about what typical magnesium levels are and what to do with patients who are having abnormalities on our other screen.
Alrighty, so let's of course first start off here with our normal range. So if we're looking at magnesium, we're typically going to see somewhere between 1.8 to 2.4 milligrams per deciliter as an acceptable normal range. Of course, this differs based on institutions in some cases, but you'll typically see about this range. Also notice that this is of course lower than values that you're going to see for an extracellular cation that are, somewhere like for sodium, for example, are upwards in like over 100, whereas here we're going to see really small values because most of our magnesium is actually within tissues. Let's first jump to the left here and talk about hypomagnesemia. Hypomagnesemia is going to be when you have below the normal range values of magnesium. This is going to be below that 1.8 milligrams per deciliter. Hypomagnesemia is more typically seen within ICU patients, with upwards of 50 to 60% of ICU patients presenting with low magnesium levels. Some of the things you might see in an individual who has hypomagnesemia are instances of tetany, seizures, arrhythmia. We may also see instances of hypomagnesemia leading to hypokalemia, which, if you remember from our previous video about potassium, would be a low blood potassium value. This might occur just because there's an increased membrane permeability with low magnesium levels, or it could be related to some irregularities in sodium potassium ATPase, which, as we already talked about, is going to require magnesium to function appropriately. So any irregularities in that could lead to some shifts in potassium levels as well. Some of the reasons why a person might present with hypomagnesemia could be instances of low intake or of low absorption. We can see this in individuals who are experiencing alcoholism, malabsorption in general, as well as instances of short bowel syndrome. We can also see concerns with increased loss of magnesium happening in the system. This can take place through GI loss, potentially through fistulas. You could see higher kidney loss, particularly related to acute tubular necrosis. We can also see low magnesium levels resulting from particular medication usage. We commonly see loss of electrolytes through diuretics, and we can also see particular magnesium concerns in instances of antibiotic usage, as well as some chemotherapies like cisplatin.
Sometimes we'll see these medications leading to increased loss, and other times we'll see the medications leading to a decreased absorption. So it can kind of go in between these two categories.
Our final kind of category of etiology here is going to be intracellular shifts. Some common instances in which we see intracellular shifts in dietetics are going to be times where our patients are experiencing refeeding syndrome, or if they're experiencing diabetic ketoacidosis. These are both instances in which we kind of suddenly have glucose substrates that are available for the body to use. And as we mentioned earlier, glucose metabolism is going to require magnesium. So this can lead to kind of a pull of magnesium to the systems that are going to start utilizing that energy source. And this can cause for our serum values to plummet. Hypomagnesemia also typically comes kind of as a cluster of electrolyte irregularities. We often see it co-occurring with low calcium status or hypocalcemia, and potentially alongside depletion of phosphorus as well as potassium, like we already spoke about. So keep in mind when you're managing that magnesium levels, you'll also probably have to be considering these electrolytes as well. So if we're thinking about treatment and management of hypomagnesemia, we can either take an oral/enteral supplementation route, or we can take an IV supplementation route. If we're looking at oral, it's important for us to know that magnesium is typically absorbed in the small intestine and particularly in the ileum. But we can see instances of GI toxicity happening if we are not very careful with the way that we orally replete magnesium levels. Because this is somewhat of a concern, we typically see people taking preference towards IV magnesium. For individuals who present with mild to moderate hypomagnesemia, we're probably going to see repletion ranging somewhere between 0.5 to 1.0 milliequivalents per kilogram per day. For individuals that are closer to the severe values, we're going to see them repleted at about 2 milliequivalents per kilogram per day. Note that if renal impairment is at all a part of this patient's kind of profile, we need to be very careful with our repletion. If they're not going to clear any of this magnesium, that's going to be too much for us to provide to their system. Also, this may need to be provided in multiple doses. It's common for hypomagnesemia to take a few days to replete, so taking it slowly and at your patient's pace is going to be the best. It can also be helpful to split out this magnesium repletion into multiple doses. And you may also need to take a few days to replete all of this hypomagnesemia to get your patient up to the normal range. So be patient with this and make sure to be mindful as to how quickly and how much you're repleting at a time. On the other side of the screen here, we're thinking about hypermagnesemia, which means we're going to be in those ranges above 2.4 milligrams per deciliter. Clinical manifestations of hypermagnesemia are particularly present when we get into this range of higher than 4.8 milligrams per deciliter. So as you can tell, quite a bit above our normal range. But individuals that are closer to this range are going to see instances of nausea, flushing. They may also experience feelings of depression, drowsiness, and muscular weakness. As for the etiology of hypermagnesemia, it's pretty common to see individuals with hypermagnesemia if they have renal impairment. So we know we're going to be helping to clear some of that excess magnesium out of the body through our kidneys. So if the kidneys aren't working and we're not able to clear as much, that would certainly be a concern for having excess magnesium levels. Another etiology for hypermagnesemia is increased consumption of magnesium, which of course makes sense. If you eat too much consistently for a long period of time, that can result in higher levels in the body. We see this typically with individuals who are consuming a lot of antacids that are containing magnesium, or you can also see it with extreme supplementation usage. We can also see hypermagnesemia happening in individuals who present with severe dehydration, if they've experienced any trauma, or if they're undergoing surgical stress. We have a few different options for management here. First off, we're going to reduce or remove any exogenous magnesium. So this could be removal from parenteral nutrition. It could be kind of that discontinuation of the antacids or other supplements to try and reduce how much we're bringing into the system. For some individuals, the use of loop diuretics may be helpful. So these are going to help to increase the amount of electrolyte loss through urine. So we're going to see magnesium loss there as well. It's kind of the opposite of what we saw for the hypomagnesemia on this side. We want to get rid of the magnesium in hypermagnesemia. And our final kind of treatment management approach here would be renal replacement therapy. But this is certainly like kind of the end of the line choice of treatment. We want to be able to kind of reduce those exogenous sources first and then potentially choose another way to kind of increase elimination. But if there's some renal insufficiency here, then that renal replacement therapy might be necessary. If you have someone present with symptomatic hypermagnesemia, you may also see the use of IV calcium. Administration of this IV calcium can sometimes help to reverse some of those symptomatic outcomes. And remember that magnesium is important for being able to kind of move calcium places. So if we have irregularities in the magnesium, we may also have irregularities in calcium as well. As you can tell from our screen here, there's a lot going on with magnesium management, many different ways that we might see the etiology of either of these instances, as well as some treatment and management plans. So hopefully this is helpful to kind of classify each of them and give you some thoughts as to why these things might be presenting in your patients. But let's wrap up over on the other screen.
Alrighty, I just have one last tidbit of information about magnesium today to share with you, and that is that from a parenteral nutrition perspective, we are typically going to infuse magnesium as magnesium sulfate. So I spent most of this video trying to convince you why magnesium is really important, literally telling you so many times that it is super important. So hopefully that got across, as well as some various ways that you might be able to help manage magnesium in your patients. If you have any questions about this video or thoughts for future videos that you'd like to see from our channel, please feel free to leave those in the comments boxes below, and we look forward to seeing you again next time.